Good evening to everyone. Good morning for people from Korea or another places all around the world. It's a real pleasure for us, for me, to present this first webinar with Korea Society of Atherosclerosis. My name is Pablo Corral. I'm the past president of the Argentine Lipid Society, pharmacology professor and researcher. And my co-chair is Dr. Kim. Doctor, please present yourself.
Yes, I will. Good evening, dear friends and colleagues. Allow me to briefly introduce myself. I am Jaetaek Kim, Professor and Chief of the Division of Endocrinology in the Department of Internal Medicine at Jung University Hospital in Seoul, and the Chairman of the Korean Society of Lipid and Atherosclerosis. It's a great honor to co-chair this webinar session alongside Professor Corral. Today, I have the pleasure to introducing our very famous Korean speaker, Dr. Chang Jung. And he graduated from Korea University School of Medicine in Seoul in 2002, earning his MD degree, and then pursued his PhD at the University of Ulsan College of Medicine in Seoul. From 2003 to 2012, he completed his internal medicine residency and clinical fellowship at the same institution. Following this, he conducted postdoc research at the University of Virginia in States from 2018 to 2020. He is currently a tenured professor at Asan Medical Center, University of Ulsan, College of Medicine in Seoul. His talk title will be The Clinical Implications of Myosteatosis in Cardio-Metabolic Health for about 35 minutes.
Thank you, Dr. Kim. Following the presentation of Professor Yang, Professor Berg will be discuss and moderate the discussion. She's full professor of clinical biochemistry and head of Lipid and Atherosclerosis Laboratory, Faculty of Pharmacy and Biochemistry, Clinical Hospital in Buenos Aires. She's actually the research director of the Institute of Physiopathology and Clinical Biochemistry in the same university, PI of the National Scientific and Technical Research Council, CONICET in Argentina, and president of the Diabetes and Lipids Working Group of the Argentine Biochemical Foundation. She's also a member of the Argentine Lipid Society, Argentine Diabetes Society, and European Atherosclerosis Society. So, Professor Yang, all yours.
Professor Jung, please.
Oh, okay. Thank you for your kind introduction, Chairman. First of all, I'd like to express my sincere gratitude for inviting me to this webinar between Argentine Lipid Society and KSoLA. Today, I plan to present my talks in the following orders as you hear. Let me start with the concept of myosteatosis first. Skeletal muscle is the largest organ in our body, comprising 30 to 40% of the total body mass, and thus plays an important role in health and aging. While there has been significant research focused on the relationship between muscle mass itself and cardiometabolic disorders over the past years, there has been limited number of studies concerning muscle quality. Meanwhile, myosteatosis has emerged as an important concept in the field of sarcopenia, and it is known to reflect muscle quality. The term myosteatosis traditionally describes three distinct adipose tissue depots found in skeletal muscle. First, intramuscular adipose tissue, which is extracellular fat between muscle groups. Second, intramuscular fat, which is extracellular fat, referring to lipid droplets within muscle cell within individual muscle fascicles. Third, intramyocellular fat, referring to lipid droplet within muscle cell cytoplasm. The number 1 and 2 is called as inter and intramuscular fat, IMAT. Now, let me try to make it more understandable to you by showing the photo of Korean meat. The definite white line beneath the fascia and within the muscle indicate the intermuscular adipose tissue and intramuscular adipose tissue, respectively. They are called as inter and intramuscular adipose tissue, IMAT, and they are active to fat deposition, and they are basically fat tissue. Regarding the red portion of the meat, although we cannot discriminate it with our eyes, it might contain good quality muscle with low intramyocellular lipid and poor quality muscle with high intramyocellular lipid. IMAT is also used as a muscle quality index, and it has been measured in the mid-thigh or abdominal muscle in previous many studies. However, the proportion of IMAT is only about 88% of the total abdominal muscle area, and is thus too small to effectively assess the entire trunk of the thigh muscle. Skeletal muscle itself is not homogeneous. Besides IMAT, the adipose tissue between muscle tissue, muscle attenuation can be very varied according to the patient, as shown in this CT image of the paraspinal muscle. Also, we can see that the proportion of IMAT is just around 10% among the entire muscle area. This discrimination within the muscle into lean muscle and fatty muscle is called as fatty muscle fraction, FMF, and it has been studied in the field of oncology and post-surgical outcomes. Subject with high fatty muscle fraction is showing worse survival rate in these non-cardiometabolic outcome studies. Now, let's explore method of assessing myosteatosis. Although muscle biopsy is a gold standard method, but it is very invasive, so its clinical implication is very limited. Therefore, imaging modalities such as computed tomography, CT, or MRI are used in clinical practice. In this lecture, we will primarily focus on CT measurement, since it's the most commonly used method in current practice and studies. When CT is used, we measure adipose tissue content in muscle using CT attenuation or density, indicating Hounsfield unit. The mean attenuation of the muscle measured by non-enhanced CT reflects the lipid content. In other words, lower mean muscle attenuation reflects higher lipid content in the muscle. So our research team used the muscle quality map derived from abdominal CT scans at the level of L3 with automated artificial intelligence software. We consider the total abdominal muscle area called as TAMA at the L3 level, which indicate all muscle in the selected axial images. This area is then divided into INAT, intra and intramuscular adipose tissue. This is adipose tissue itself, and skeletal muscle area, SMA. And then, based on the attenuation levels, the skeletal muscle area itself is further categorized into low muscle attenuation area and normal attenuation regions, called as LAMA and NAMA, respectively. Next, we calculated the percentage of normal muscle from the total area, naming it the NAMA-TAMA index. Lower percentage of normal area indicate more lipid infiltration and poor muscle quality. So in some studies, we defined myosteatosis as falling within the lowest quartile of the NAMA-TAMA index. In this slide, I have listed several other myosteatosis indices that we have used in our analysis. NAMA, normal attenuation muscle area, adjusts for body mass index, NAMA BMI index, and NAMA TAMA index, the index that I previously explained, and served as a marker for good quality muscle. The lower attenuation muscle area, LAMA, adjusts for BMI, or IMET itself was used as an indicator for poor muscle quality. Let's move on to the next part. In this part, I will deal with the clinical implications of myosteatosis in various cardiometabolic disorders that our study started so far. The first topic is the association between sarcopenic obesity and poor muscle quality measured by our method. Sarcopenia, defined as a decrease in skeletal muscle and function, has been described as a geriatric condition. Sarcopenic obesity is a clinical and functional disorder characterized by the coexistence of sarcopenia and obesity. Clinically, the combination of sarcopenia and obesity has a significant and negative implication, including increased risk of cardiometabolic diseases, frailty, and mortality. And myosteatosis can be a key pathophysiologic feature of sarcopenic obesity related to poor clinical outcomes in this phenotype. This cross-section study included 23,000 individuals who had abdominal CT scan during our health screening examination. We used the same cohort for our subsequent studies, which I will introduce in the latter part of my lecture. After applying for exclusion criteria as shown here, they were categorized into 4 groups according to the presence of sarcopenia and obesity. Sarcopenia was defined as using BMI adjusted perpendicular skeletal muscle mass, and BMI of 25 or higher was defined as obesity as the Asian specific criteria. We used NAMA-TAMA index in this study for the myosteatosis, and myosteatosis was defined as having the lowest quartile of the NAMA-TAMA index, as I mentioned earlier. As you can see here, participants with sarcopenic obesity had lowest NAMA-TAMA index, the index of good quality muscle, than the other groups. The prevalence of myosteatosis was significantly higher in the participant with sarcopenic obesity than participant with a single component or a normal group. Compared with non-sarcopenic obesity group, reference group, the risk of myosteatosis was almost quadrupled for the people with sarcopenic obesity, even after adjusting for other confounding factors. However, the conventional marker for obesity and sarcopenia also showed a significant correlation with myosteatosis index. Because here, the BMI itself revealed a significant negative association with NAMA-TAMA index, while perpendicular skeletal muscle divided by BMI, or marker of sarcopenia, had a positive correlation with good quality muscle In other words, both markers for obesity and sarcopenia are closely correlated with the myosteatosis degree. So in conclusion, sarcopenic obesity was closely associated with myosteatosis, which represent poor muscle quality. So we need to develop the therapeutic interventions for myosteatosis in people with sarcopenic obesity. Then, how about its relationship with insulin resistance? As you know, insulin resistance is a major pathogenesis of various cardiometabolic comorbidities. Skeletal muscle is the primary source of insulin-mediated glucose metabolism. Therefore, lipid accumulation in this area, termed myosteatosis, could play a key role in insulin sensitivity and deterioration. Under this background, we aim to evaluate the association between myosteatosis and insulin resistance in the same cohort. We can see that in both gender, as the amount of good quality muscle increases, the insulin resistance decreases, and poor muscle quality increases, the insulin resistance increases. Regarding the insulin sensitivity, we can see the exactly opposite relationship between the myosteatosis and insulin sensitivity index, which was measured by SPICE index calculated from this formula. As the amount of good quality muscle increase, the insulin sensitivity increase also, and as the poor muscle quality increase, the insulin sensitivity decrease. In summary, higher HOMA-IR level and a lower insulin sensitivity index were closely associated with a higher amount of poor quality muscle, as well as lower amount of good quality muscle. So myosteatosis is closely associated with insulin resistance, which is the definite cardiometabolic risk factor. Next topic is myosteatosis and hypertension. Previous studies on the relationship between myosteatosis and hypertension are scarce and discordant. All these previous studies reported that advanced myosteatosis was significantly associated with higher hypertension risk. However, the indices with or without statistical significance differed among studies, even with the same ethnicity. One possible reason is the limitation of the conventional myostasis marker they have used. IMAT, as I previously mentioned, accounts for only a very small portion to represent the whole muscle, body muscle, and the muscle attenuation is highly susceptible to the influence of CT contrast. Furthermore, there has been no studies, those studies have enrolled Asian population so far. In our study, in every adjustment model, the odds ratio for hypertension was significantly increased with lower NAMA BMI, less normal muscle area, regardless of gender. Individuals with lowest quartile of normal muscle area had a 2.3-fold higher risk of hypertension in men and 2.6-fold higher risk in women compared to individual with the highest quartile in fully adjusted model, including visceral fat to subcutaneous fat ratio measured by CT scan. Besides this NAMA BMI index, we have used other myosteatosis index in this study, as I mentioned earlier, including skeletal muscle area divided by BMI, the NAMA-TAMA index, and all results indicate that advanced myosteatosis was associated with higher hypertension risk in Asian population. The editor of this journal wrote the editorial entitled as the myosteatosis, a potential missing link between hypertension and metabolic disorders in Asian population. In this editorial, they have suggested the possible mechanism linking myosteatosis and hypertension and metabolic disorders that show here, that showed they suggest that the high prevalence of hypertension in the Asian population, despite the relatively lower BMI and lower prevalence of obesity, partly be due to the relatively higher visceral fat and myosteatosis. In conclusion, hypertension, our study showed that hypertensive subjects had more advanced profile of myosteatosis as assessed by abdominal CT scans compared to their normal tensive counterpart, and higher NAMA BMI, which reliably represent low fat muscle, was significantly correlated with the lower risk of hypertension. Now let's consider its relationship with atherogenic dyslipidemia that we have published recently. Muscle and dyslipidemia are closely interconnected. Skeletal muscle are a key player in regulating lipid metabolism in the body. They help to clear triglyceride and cholesterol from the bloodstream, which can have a positive impact on lipid profile in the blood. So far, there have been numerous studies which investigate the association between muscle mass itself, not quality, and atherogenic dyslipidemia. But its relationship with muscle quality was limited and inconsistent. Meanwhile, our research team has published the relationship between muscle quality measured by NAMA-TAMA index and coronary artery calcification. Although several studies show that the low muscle mass, not quality, was associated with cardiovascular disorders, only few studies investigated the association between muscle quality and coronary atherosclerosis. She showed that a higher proportion of good quality muscle was significantly associated with lower prevalence of significant coronary artery calcification. This association was more prominent in women compared to men and persisted after adjusting for traditional cardiovascular risk factors, including insulin resistance marker and visceral fat area. In this background, we aim to reevaluate the relationship between myosteatosis and atherogenic dyslipidemia in a large population in those who were not taking any lipid-lowering medications. Let me show you the result. In men, as the NAMA-TAMA quartile decreased, in other words, as the good quality muscle decreased, the odds ratio for dyslipidemia, according to the HDL cholesterol, triglyceride, calculated small dense LDL cholesterol, and ApoB-A1 ratio definition, significantly increased, although the NAMA-TAMA quartile in males were not significantly associated with higher risk of dyslipidemia, defined LDL cholesterol more than 160 milligram per deciliter. And women, a decrease in NAMA-TAMA quartiles, in other words, a decrease of the good quality muscle, resulted in a higher odds ratio of dyslipidemia according to the HDL cholesterol, LDL cholesterol, and calculated small dense LDL cholesterol conditions. Although, according to triglyceride and ApoB-A1 ratio definition, the odds ratio was not statistically significant in female population. When you perform the multiple linear regression analysis, most lipid parameters showed significant association between myosteatosis index in both genders. So in conclusion, we found that myosteatosis and atherogenic dyslipidemia are closely related, evidenced by the decline in the prevalence of dyslipidemia as the healthy muscle component in our code. So ectopic fat accumulation in muscle contributed to atherogenic dyslipidemia and ensuing cardiometabolic diseases. The next cardiometabolic disorders I'd like to mention is fatty liver disease. Sarcopenia, a muscular disease characterized by the gradual loss of muscle mass and strength is also suggested to be one of the risk factors of non-alcoholic fatty liver disease. However, as most previous studies measure the muscle mass, not the muscle quality, to define sarcopenia, the association between sarcopenia and NAFLD should be revisited by incorporating the concept of muscle quality. In this background, we have analyzed the association between various myosteatosis index and sonographic NAFLD and its severity and liver fibrosis using non-invasive markers. And we found that the higher proportion of good quality muscle was associated with lower risk of NAFLD and fibrosis, as summarized in this graphical abstract. For liver fibrosis, we used FIB4 and NFS score in those with NAFLD detected by sonography. Both markers for liver fibrosis show decreased as the good quality muscle measured by Namatama index increased. So we have concluded that poor muscle quality is suggested to be the potential risk factor for NAFLD and liver fibrosis. Diagnosis as NAFLD is based on the inclusion of secondary causes of hepatic steatosis, such as excess alcohol intake and viral hepatitis. Recently, the nomenclature of NAFLD has been criticized for disregarding the synergistic effect of these components and the involvement of metabolic variables. To address this issue in 2020, metabolic dysfunction associated fatty liver disease, MAFLD, was proposed as a better term for liver disease caused by metabolic dysfunction. A proposed diagnostic criterion for MAFLD was the accumulation of liver fat in conjunction with obesity, type 2 diabetes, or metabolic dysfunction indices independent of heterogeneous etiology. And more recently, the MAFLD was also renamed into MASLD, MASLD, mentioned here, metabolic dysfunction associated steatotic liver disease. I will skip the detailed diagnostic criteria for the diagnosis of MASLD due to the time limit. Under this background, we aim to explore the prevalence of fatty liver disease, FLD, and to assess both the quantity and quality of skeletal muscle using each of these diagnostic classifications. In our study, the participants were classified into 4 categories: neither steatotic liver disease, NAFLD only, MASLD only, or both steatotic liver disease. As shown in this slide, in participants with MASLD exhibited a significant higher association with sarcopenia and myosteatosis, and individuals without NAFLD or with NAFLD only. As shown here, the NAFLD only group showed no significant association between sarcopenia and myosteatosis. So in conclusion, we found that participants with MASLD exhibited a higher correlation with sarcopenia and myosteatosis. Employing the MASLD concept rather than NAFLD proved to be more effective in distinguishing individuals with both reduced muscle mass and compromised muscle quality. Lastly, let me introduce our recent analysis on the association between myosteatosis and cardiac function, which are under review now. In our previous study, we demonstrate that myosteatosis were closely associated with insulin resistance, as shown here, as I shown before. And insulin resistance can induce metabolic disturbance in cardiomyocyte also, and eventually impair cardiac function. In this background, we aim to investigate the impact of myosteatosis on cardiac function, evaluated by 2D echography in an asymptomatic Korean population after applying for very strict criteria as shown here. A cardiac function was assessed through transthoracic echocardiography. Conventional two-dimensional and Doppler images were obtained, and the following variables were measured. Systolic function was assessed by LV ejection fraction, and how LV hypertrophy was assessed by LV mass index, and diastolic function was assessed by E wave and E of EA ratio and E prime and E of E prime ratio. As a result, multiple regression analysis revealed that the Namatama index, the good quality muscle, was positively associated with EA ratio in both genders, and negatively associated with E of E prime ratio, with the association remaining significant even after adjusting for covariate, including a visceral fat to subcutaneous ratio. A significant association were observed between Namatama index, the good quality muscle index, and LV ejection fraction and or LV mass index in women, but this statistical significance had disappeared after covariate adjustment. This figure represents the scatter plots between Namatama index and diastolic dysfunction indices. As I mentioned earlier, the Namatama index was negatively associated with E of E prime ratio and positively associated with EA ratio, all indicating that myosteatosis was significantly associated with cardiac diastolic dysfunction, not systolic dysfunction. Among these covariates, age, gender, hypertension, diabetes, and triglyceride, and visceral to subcutaneous ratio were independently associated with E of E prime ratio. All these variables were well-established factors for cardiac dysfunction as demonstrated in various previous other studies. However, in our study, the association between myosteatosis measured by Namatama index and diastolic dysfunction remained significant even after adjusting for these conventional variables. So the degree of myosteatosis was significantly associated with diastolic dysfunction in the symptomatic population, while systolic function remained unaffected. This finding suggests that ectopic fat deposition in skeletal muscle might be an important predisposing factor in cardiac dysfunction. So let me summarize my talk. When you summarize other studies and our studies, there is consistent evidence that CT-derived myosteatosis contribute to dysglycemia, insulin resistance, type 2 diabetes, and inflammation, and to some extent, dyslipidemia, independent of general obesity. It may serve as a tool for metabolic risk prediction. Although the exact molecular mechanism linking myosteatosis and cardiometabolic diseases is the area of further research, several potential mechanisms, including increased muscle inflammation, increased lipolysis, and impaired myokine secretion have been suggested so far. So in summary, our research team has delved into clinical implication of myosteatosis using CT scans and uncovered some significant connections. We found that myosteatosis was closely linked with several cardiovascular risk factors such as insulin resistance, abnormal lipid levels, and high blood pressure. Furthermore, we have identified association between myosteatosis and sarcopenia, obesity, and MASL. These findings suggest that myosteatosis could potentially serve as a crucial missing link between metabolic imbalances with cardiovascular diseases. Further studies are essential to explore clinical interventions aimed at improving myosteatosis and catching its clinical benefit. It will be necessary to consider this concept in connection with recently spotlighted anti-novel, anti-obesity medications. When weight loss is induced by this new anti-obesity medication like GLP-1 and GIP dual agonist tirzepatide, both fat and muscle mass decrease after the treatment of tirzepatide. However, since the reduction in fat is much greater than that of muscle mass, it has been shown that relative proportion of muscle mass actually increase. However, compared to this effect on muscle mass itself, the impact on the qualitative aspect of muscle is not well established, suggesting further research in this area is also necessary. Thank you for your careful attention.
Thank you very much, Professor Yang, for your outstanding lecture. It was really, really amazing. So next, Professor Berg, Gabriela will be us some feedback, question, and recommendation or comments.
Yes, first of all, thank you, Dr. Yang, for your wonderful and challenging conference. In fact, several questions arise along your talk, even though you answer most of them. To my knowledge, yours is the first study to investigate the association between muscle D and myosteatosis, and to evaluate the quantity and quality of muscle. Regarding this point, I think that previous studies in NAFLD patients showed controversial results, probably as consequence that nearly 40% of NAFLD patients are normal weight, even they have normal or abdominal obesity. So do you think that the controversial results could be consequence that your NAFLD patients that you showed in your slides were lean and without abdominal obesity? That's one of my first questions. And by other side, it's amazing the concept of the crosstalk that we know that exists among muscle, liver, and adipose tissue. And in your nearly last slide, you showed muscle in the center of the picture, but probably that is a consequence that muscle is the primary organ responsible for insulin-mediated glucose disposal. Hence, a decreased muscle mass may cause impaired glucose metabolisms. Besides, this complexity of the crosstalk among these tissues, to your idea, which do you think is the order of these actors, named muscle, liver, and adipose tissue, come on stage? And also, do you consider that sarcopenia or myosteatosis are cause or consequence of MAFLD?
Yeah, thank you for great comment and questions. The first question is regarding the lean NAFLD patient, right?
Yes.
So, there are some participants who have NAFLD, even though they are very normal weight or underweight. So, however, when you look at our data, the non-obese NAFLD population has a very benign characteristics regarding to sarcopenia and myosteatosis. I don't know why lean NAFLD patients exist. There are some suggestions that they are genetically defect in regulating hepatic lipid oxidation. So basically, they can have NAFLD based on the imaging modalities, but they are mostly clinically benign. Even even when they do not have any metabolic alteration. So simple NAFLD is seems to be very benign if they do not have any metabolic disorders. And the second question was about
if you which do you consider is the start in this crosstalk among muscle, adipose tissue, and liver in the patients with insulin resistance?
I don't have any clear answer for that because that is very controversial area. So that question is regarding the which active fat is most detrimental to our cardiometabolic health. So mostly, most researchers agree that liver fat is the most deleterious effect on our cardiometabolic health. However, not only this liver fat, but also any other metabolic visceral ectopic fat accumulation, including muscle or cardiac fat, might have some clinical significance in our field. So mostly liver fat is most important, but other ectopic fat deposition is also play a very important role.
Thank you. And another question regarding the NAMA-TAMA index, even though at the last of your presentation, you showed that you adjusted by gender, but I have this specific question, if it's the same cutoff point for men and women in NAMA-TAMA, even, yes?
Yeah. That's a very good question. Actually, I didn't show the data of our reference range of NAMA-TAMA index in both gender or according to the age. There is no suggested specific criteria for NAMA-TAMA index to diagnose myositis. However, we calculate the G-score, like bone marrow density, in our health cohort. And as you mentioned, there are gender-specific cutoff point for myosteatosis, so it should be applied differently to genders.
Thank you so much. And if I can, one more question. Some years ago, we developed an animal model of insulin resistance, and we observed that in a heart muscle, there was a decrease in lipoprotein lipase activity, and one of the main actors in allowing the free fatty acids to get into the muscle was endothelial lipase. Which role do you give to these two enzymes in regulating the flux of fatty acids toward the cardiac muscle? Or do you think that there are another actors that have a most important role?
I'm sorry, I don't have any knowledge on that.
Okay, thank you. Thank you so much. There are a question from the audience. Dr. Laura Schreier says your talk it was very interesting, and she asked if you consider from a quantitative point of view that fat deposits in muscles are as important as pro-inflammatory source as liver fat, for example, in metabolic syndrome.
Yeah, thank you for the question. A very important question. I think both fat deposition is very important in metabolic syndrome, but when we compare the degree of contribution of both fat, as I mentioned in your question, liver fat is the most large contributor to metabolic disorders. Liver fat is the most important, but muscle fat might be hidden, missing causal factors for metabolic disorders.
Thank you, Dr. Jung, and I'm searching if there are more questions.
Yes, Dr. Yang. There is a concept about paradox athlete. So that refers to highly trained individuals who develop, despite having significant muscle mass and engaging in regular physical activity, develop myosteatosis. This condition contradicts the usual association between high physical activity levels and optical muscle quality. In your opinion, what are the clinical impacts of paradoxical myosteatosis in athletes, particularly concerning about their metabolic health or like performance and long-term outcomes? Do you have any data about that?
You mean that a very strong athletic can have myosteatosis even they work out a lot?
Yeah, absolutely.
Oh, I didn't know about it. I didn't know about it.
Okay.
Yeah.
And another question regarding the physical activity and which is the best activity in order to improve this condition? Is aerobic? Is non-aerobic? Is a combination of these two type of training?
Yeah, there are very limited studies to improve the myosteatosis by non-pharmacological interventions. So, and as far as I know, the both combination of aerobic and resistant exercise might be the best tool for improving myosteatosis so far. However, there are no pharmacological agents to improve myostasis so far, but there are currently one strong candidate for treating myosteatosis as well as sarcopenia, called as myostatin activin inhibitor. It is developed by some big pharmaceutical company and is showing some promising result in improving both muscle mass and quality.
Thanks. And my last question is regarding diet. Do you have any data or any know about a special pattern of dietary like a keto diet or long fasting diet or in order to impact of myosteatosis?
I'm not sure about it, but I think diet itself might be very adjunctive to reduce muscle mass or myosteatosis. I'm not sure about it.
Thanks.
And one more question, Dr. Yang. Do you think that, have you evaluated Namatama index alone, or have you compared its ability to evaluate muscle quality against the measurement of strength in the muscle? Or do you think you can add the measurement of strength to Namatama, or do you think it's enough and it's not necessary?
Okay. Yeah, muscle strength should be considered in the diagnosis of sarcopenia first. However, unfortunately, we don't have much data on muscle strength, but recently we are accumulating the data for muscle strength. However, Namatama index is strongly is the marker of muscle quality, and muscle strength is largely dependent on muscle quality, not muscle mass. So we expect that there might be some strong correlation between Namatama index and muscle strength. So Namatama index is just a surrogate marker for muscle strength. So clinically, muscle strength should be considered.
Thank you very much. Well, Pablo, I don't know.
Yes, we have another question here in the chat from Laura. She asking about the LP activity in myosteatosis. The question is for Gabriela and for Dr. Jung. LP activity and myosteatosis. Any relationship?
As far as I know, there is no studies which investigate both correlation, and unfortunately, we do not data on LP(a).
Well, we have data about LPL in insulin resistance situation in adipose tissue and muscle. And our observation is that the activity of the enzyme is decreased in both in muscle and adipose tissue, according to the insulin resistance. So as you show that there is an increase in small dense LDL particles that are associated with namatama, the increase in small dense LDL probably is associated with hepatic lipase activity, which probably is increased in those patients because of their insulin resistant states. It's a very nice result also. Very nice.
Okay, thank you for your comment.
Dr. Yang, the inflammatory biomarkers like cytokines, and do you think that those cytokines comes from the muscle and the myosteatosis site of this ectopic fat deposit, or is a consequence of the liver fat disease, and is the liver who relays these cytokines?
Yeah, there are many cytokines which are secreted from muscle itself, called as myokine. So I think most cytokines are secreted from adipose tissue or liver. There are also many other cytokines secreted from muscle, inflamed muscles. So myokine is a very emerging concept.
There is one more question from Dr. Martin Lobo. While he thanked Dr. Jung for the excellent presentation and asks if the diagnosis of myosteatosis could be considered as an enhancer of cardiovascular risk, such as other biomarkers as LPA or CRP.
Yeah, absolutely. It can be an answer for cardiovascular risk, but because it is very hard to measure in clinical practice, but it is definitely an enhancer of severe risk. But it is not so strong as other conventional cardiovascular risk factors.
Thank you. And one more question from Dr. Walter Mason. What impact would statin have on myosteatosis?
Yeah, I think there is a very little possibility that statin can deteriorate. Statin can induce muscle fiber damage, or statin have very pleiotropic effect. It may have a positive impact or negative impact, but we don't know. I haven't seen any data on that.
Okay, a field to study. Okay. Thank you so much.
Well, Dr. Kim, do you want to close the meeting? And
Yes. It's time to see our patients, and this is approaching 9 o'clock. So I will close this session, and I look forward to hosting regular webinars with Argentina Lipid Association and the possibility of mutual visit in the next year. Thank you very much, Professor Corral and Professor Berg, and many Argentina colleagues. Thank you very much.
Thank you so much.
Thank you.
thank you. Bye-bye. Take care. Thank you.
Have a good night.
Have a good night.
Have a
Thank
good
you.
day. Have a good day.
Thank you.
Good
Bye.
day.
Bye.